Good afternoon, everybody. Good afternoon, Dr. Uam, and thank you. He pulled me again to the bedder. Last bedder was 3 years ago. It was about hypogonadism. I remember the subject, hypogonadism in diabetic patients. So thank you, Dr. Uam. Thank you, AstraZeneca, for giving me the opportunity to talk about this important subject. As you see, the topic is revolutionizing type 2 management to reduce cardiorenal risk. It is revolutionizing treatment, and I think in our time it's the SGLT2 inhibitor, GLP-1, and the metabolic surgery are revolutionizing the treatment of diabetes nowadays. I am more a fan of metabolic surgery and SGLT2. Tomorrow I am going to give another talk about SGLT2 inhibitors. Maybe you can share later why I'm more toward SGLT2 than GLP-1 agonists. So we're going to focus about the chronic kidney disease in diabetic patients, not about the metabolic aspects or the cardiac aspects. It's mainly the focus on the renal and chronic kidney disease aspects. I noticed the audience, we have different audience, GPs, endocrinologists, cardiologists, and nurses, diabetic educators. So I'm going to take it just from basic, bear with me, so that at least at the end we have a clear pathway what to do and how to interpret this valuable data into clinical practice. Okay, this is just a basic, the definition of chronic kidney disease. We have to know the definition of chronic kidney disease. Most of you know of this. Just a reminder. To define CKD, you need 3 things. You need a duration. You need 3 months. 3 months is given only for the chronicity, so you need 12 weeks of time to address the chronicity. You need either biochemical, structural damage in the kidney, imaging, or through urine microalbumin, or a decrease in GFR less than 60 ml per minute. So we have to be clear about this definition. Whenever you have an abnormal urine microalbumin, an abnormal imaging in the ultrasound, or a reduced GFR, you have to repeat that in 3 months' time to label the patient as CKD, and from there we'll take it on. Once you label the patient CKD, you have the staging. Everybody is familiar with the staging from stage 1 to stage 5. Just focus on the stage 3 because most of our data will be around this stage. And from stage 3 and forward, you see that these things will be accelerated quickly. Stage 3 is a GFR less than 60 ml per minute. We have stage 3A and stage 3B from 45 to 60 ml per minute, and from 30 to 45 ml per minute is stage 3B. Okay, this is very important. So you diagnose that your patient have chronic kidney disease biochemically, by reduced GFR, by imaging. What is next? What is next is that you assess the cardiovascular and renal risk of this patient. This is a diagram from KDIGO organization, and it's a nice one. You can see easily. So there is a grading on the left side of the screen. You see grading from stage 1 to stage 5, and then you have the level of microalbuminuria. And you can see the lower you go in staging, the advanced stage, and the more you go in albuminuria, the risk of the patient increased significantly. As you can see, even those patients with normal albuminuria or early stages of kidney disease, although it is in green, they are not risk-free. They are labeled as low-risk patients. So in diabetic patients with chronic kidney disease, you don't have risk-free patients. You have low-risk patients to a very high-risk patients. And this is the next step. Once you diagnose your diabetic patient, you screen them. Then you put them, you stratify the risk of having chronic kidney disease through this, combining the microalbuminuria with the staging of the chronic kidney disease using the GFR. Important, again, it's not only the chronic kidney disease, not only dialysis and renal failure, it has a lot of things connected to it. It's associated with increased all-cause mortality, reduced life expectancy, increased cardiovascular events, hospitalization, affects the quality of life, and finally, all of these will interpret into increasing and cost burden on the health sector. This is a very nice slide. It shows clearly that as the kidney function, the GFR reduces, there's almost linear increase in cardiovascular events, hospitalization, and even mortality. You can just look at most of the slides, you can see, once the GFR goes below 60, which is a stage 3A, you see almost a linear increase in the cardiovascular events, hospitalization, and mortality. And we're going to talk about this very soon in coming slide, that once you reach the stage 3A, the things will accelerate very quickly, and even within 2 years, the acceleration will be quicker over time. So preferably you intervene before you reach this stage of chronic kidney disease. Again, once you know about the mortality and the morbidity associated with hospitalization and events, you can see that this all interpret and into 25% of all healthcare expenditure on chronic kidney disease and its complications. So the KDIGO recommends screenings in certain high-risk population, which we are mainly concerned here are diabetic patients and high blood pressure patients. We know that in chronic kidney disease patients, almost 42% are diabetic and 58% they have other causes of chronic kidney disease. Majority are diabetic patients, so that's why there is a focus on diabetic patients as a cause of chronic kidney disease. This is a very important slide. Everybody is aware that the complication starts much earlier, even before the diagnosis of type 2 diabetes at the pre-diabetic phase. But once you diagnose type 2 diabetes patient, you know that 20 to 25% of these patients already have complications at the time of diagnosis. And we know 1 in every 4 of these patients will already have microalbuminuria as a diagnosis. So complication already started at the time of diagnosis. There is no excuse to wait or delay your management for further time. Again, this is a strange slide. It shows, although we know that the complication of chronic kidney disease and diabetes, there is a reason in diagnosing the chronic kidney disease. There is some, I mean, maybe we can discuss this later, a reason, an inertia from physicians, from patients, from somewhere, even at the higher stages of chronic kidney disease, the majority, almost half of the patients are only diagnosed, the other half are not diagnosed. So I hope after this study, after this presentation, we'll know when to screen, when to screen and how to screen and what to do, even if you screen your patient and he's normal. Okay. Again, you have very simple, available, inexpensive, easy tests that you can, tools that you can use to screen your patient for chronic kidney disease. You can use a blood test using the GFR, estimated GFR, or you can use a simple urine spot test to check for urinary albumin-creatinine ratio. And these tools can be used for screening. And then you use that diagram to stratify the risk of your patient where he stays in the low risk, moderate, or very high risk of renal and cardiovascular disease. These tests are easily doable, and we do this with every visit of our patient. But there is a problem in labeling and diagnosing chronic kidney disease, and there is a problem in the time of intervention as well. Again, earlier detection means you are giving your patient more years of life. The earlier you intervene, the more time, and better, even not years, it's quality of life. Dialysis-free years, complication-free years, so the earlier you intervene, the better quality of life and more life expectancy you are giving the patient. This is very important. This is a guideline. Everybody of us likes guidelines, what to do when you have a patient like this. This is the KDIGO guidelines involving about the assessment of patients with chronic kidney disease in general. But this applies for diabetic patients, hypertensive, other high-risk patients. We'll focus on diabetic patients more. So what happens if you just screen your patients? You found those patients who are at increased chronic kidney disease risk. This includes diabetic patients, hypertensive patients, older age group. You screen using these tools. We said the estimated eGFR and the urinary albumin-creatinine ratio. What happens? And you have to repeat this test. We said in 3 months to label them as chronic kidney disease. We need at least 2 tests 3 months apart. So you have 2 scenarios. One that you already find an abnormal result, and you classify, when you diagnose the patient with chronic kidney disease, from there you can go and intervene. But what about if you do the test, screening test, and your patient has no microalbuminuria with normal kidney function? End of story? No, it's not end of the story. Again, you have to periodically, repetitively do repeated evaluation. Whether your patient has evidence of chronic kidney disease or does not, this patient needs to be periodically followed, because by time you can detect the progression of these kidney diseases. We mentioned this, and you saw that from that few graphs easily, that once you reach stage 3A, creatinine clearance of less than 60, there is some rapid acceleration in the progression of kidney failure. So preferably, we need to intervene before patient reaches this stage, the eGFR of 60, or stage 3A kidney disease. Again, this is the first time that all the guidelines, cardiac guidelines, the American Diabetic Association, the European Association for Study of Diabetes, KDIGO guidelines, all of these guidelines, they agree that SGLT2 inhibitors should be the main pillar of the treatment. It reduces the renal events, new renal event, progression of renal events, reduces cardiovascular mortality, reduces all-cause mortality, improves glycemic control. So there is abundance of evidence, actually in diabetic, and now they are going to share that even in non-diabetic patients there is some benefits and such. So all the guidelines, whether you have a patient with evidence of chronic kidney disease or high cardiovascular risk patient or a poor metabolically controlled, maybe tomorrow we can talk more about this, they are all advised to use early use of SGLT2 inhibitors to reduce the morbidity and mortality of these patients. Again, now we are thinking guidelines. We're going to talk about the American Diabetic Association, the KDIGO guidelines. They are all focused now. Initial focus was on glycemic control, HbA1c targets, or other risk factor, aggressive targeting reduction. Now we added that cardiorenal protection is an important pillar. Actually, you need to look at this even in the primary, before this develops, because I'm going to show you evidence that you can prevent that before this develops. And even if it develops, you can sometimes regress the evidence of damage. So it is one of the important pillars, not only glycemic control, not only blood pressure control, lipid control, antiplatelet. It seems that this is the standard of care which we do for most of our patients. Most of our patients, according to these recent guidelines, should be on SGLT2 inhibitors or GLP-1, depending on their cardiovascular risk profile. These are the latest guidelines. Again, you can see everything changed except the lifestyle modification. Glucophage is still the first line. You have to do comprehensive lifestyle modification, and metformin still has a higher rank of usage. After that, then patient risk, cardiovascular risk assessment, whether established cardiovascular disease, or chronic kidney disease or heart failure. From there, then choice of medication, and you see the choice of medication in the majority of the cases are SGLT2 inhibitors, or those with established cardiovascular disease. A GLP-1 will be a good choice, but I think I'm more toward the SGLT2 because, as I'm going to show you, you have evidence of primary prevention, not only those with established cardiovascular disease, you are preventing secondary outcomes. In SGLT2 inhibitors, there is a lot of data that you can do better. You can even prevent these new onset cardiac or renal events. Okay, this is just exactly what I said. This is important. Just notice that initially it was an HbA1c glycemic target, and now it says clearly, consider independently of baseline HbA1c or HbA1c targets. I'm going to talk about two scenarios you see in your clinical practice. You see somebody, a diabetic patient with HbA1c of 7%, who's well controlled on his whatever medication he's taking. And the other hand, you see a patient with very poorly controlled HbA1c of 14%. You have different approaches. You see this patient is poorly controlled, 14% HbA1c, or the other one is well controlled on, let's say, metformin alone or other sort of treatment. Should this change, these guidelines change? Yes. Regardless of your initial HbA1c, regardless of your baseline medication, I'm going to show you that SGLT2 inhibitors is going to benefit your patient throughout the course of the disease. This is important. Again, this is a shift. Can we do more to protect kidneys of our type 2 diabetic patients? Yes, we can do, and the guidelines has recently changed. In the past, it was glucose metabolically concentric approach. Now we know that no, it's not I'm going to show you a few slides showing that even if you address all the risk factors of, and aggressively treat your diabetic patient, still you have something called residual risk. You are not eliminating the risk of cardiovascular and renal disease, even using the standard, the ACE inhibitor, the ARBs, the mineralocorticoid receptor antagonist, lifestyle modification. Still there is a residual risk which you have to address. And this is addressed by the SGLT2 inhibitors, as we are going to see. Now the disease, you look at this patient, regardless of the HbA1c control. It is important, we look at the HbA1c, but it shouldn't be the main target. We are looking more into cardiovascular and renal risk factor of these patients. This is just talking about dapagliflozin, the Forxiga, and some studies shows that you have a 47% relative risk reduction in composite in a new onset or progression of nephropathy, which is very important. Very important. You are not talking only about secondary prevention. You have a diabetic patient with microalbuminuria or macroalbuminuria. You want to prevent progression, even new onset. So you can do something in primary prevention of such patient, and 47% relative risk reduction. You are doing a lot to your patient. This is a beautiful slide. I mean, after you see this slide, I'm sure you will change your vision, your approach to diabetic patient. This is looking at the kidney disease and the microalbuminuria itself. These are the different patients that you may see in the clinic. You can see a patient, a newly diagnosed patient, or a diabetic patient who has normal albuminuric. And you are afraid that by time, with diabetic poor control, or by time by itself, he can progress to microalbuminuria or even macroalbuminuria using a SGLT2 inhibitor. And here, the Forxiga, the DAPA, can reduce that progression by new onset microalbuminuria by 21%. Even if this patient was already microalbuminuric, as we said, 25% of patients at the time of diagnosis, they have microalbuminuria. Can you do something about it? Yes, you can prevent the progression into macroalbuminuria by 46%, which is great. Assume even in the worst scenario, this patient already have, from the beginning, macroalbuminuria, or they developed by time macroalbuminuria, you can have 54% regression of this macroalbuminuria. So you can do a lot throughout the continuum of the diabetic kidney disease patient, just early from the beginning, from the normal albumin till the late, once the patient develops macroalbuminuria, you can even 54% cause regression, which is great for this patient. This is just showing a shift in guidelines, the KDOQI guidelines for diabetic patients from nephrology side of view. It's one of the after lifestyle modification, exercise, diet. Still now it is one of the core treatment for chronic kidney disease, especially diabetic chronic kidney disease, in addition to metformin, RAS blockers, statins, and other risk factors. Now we see SGLT2 inhibitors. They are one of the main pillars and initial pillars of the diagnosis of the treatment in chronic kidney disease. This is an important, talking about Forxiga and dapagliflozin. It's the first and the only indicated in the management of chronic kidney disease. Important here, they have studied patient populations with or without type 2 diabetes. They have data also, those with normal albuminuric and those with microalbuminuric. So you can look at these patients throughout the course of the disease. Cardiovascular protection as well, even in the kidney trials, you have seen cardiovascular protection. New about the DAPA is this is important because I'm going to have questions regarding this. You can use in CKD patients, even with the GFR of 25, up to 25 ml per minute, with or without type 2 diabetes. So this is good. You can use it throughout the course of the kidney disease, even with a very advanced stage 4 and kidney disease you can use, and you have evidence that it's not harmless. It does not cause renal impairment. Actually, it improves the renal function, even at very low GFRs. This is important, again, for Forxiga reduction, composite decline in kidney function, and kidney disease, cardiovascular and cardiovascular death by 49%. So we are achieving benefits in both renal and cardiovascular events by 40% when you use dapagliflozin. This is a weird slide. This shows that both diabetic and non-diabetic patients will benefit from SGLT2 inhibitors and DAPA, and for some reason, non-diabetic patients also have more benefit, more than 50% reduction in relative risk of developing chronic kidney disease. So diabetic or non-diabetic, microalbuminuric or normal albuminuric, DAPA has a good evidence, quality evidence-based medicine that you will help your patient. Again, you are not talking about cardiovascular mortality, cardiovascular event, chronic kidney disease event. You are talking about all-cause mortality, 31% reduction in all-cause mortality. You are adding years to your patient's life. 6.6 years delay till the time of dialysis. Again, we mentioned this clear. You are not going to eliminate the risk. You are going to improve it, give your patient more quality of life, quality of time. 6 to 7 years dialysis free. I mean, this is an achievement for somebody who's a very high risk patient, somebody who is already on standard medication, or what benefits that he's, or the medication that according to standard of care, statin, antiplatelet, ACE, ARBs, mineralocorticoid receptor antagonist. Adding SGLT2 and DAPA to this, you can add 6 to 6.5 years of quality life. I mean, this is an achievement for your patient. This is very important. This is one of the important messages. Would you initiate Forxiga or dapagliflozin, SGLT2 blockers in general, in a patient who has controlled HbA1c with declining kidney function? This is very important. See, if I said you have two scenarios. You have one scenario, you have a patient already well-controlled type 2 diabetic patients on simple medication, or maybe even on insulin. He's controlled on glucophage, on insulin, or on sulfonylurea. He's still not on SGLT2 inhibitor, not on DAPA. Would you start or shift the patient to dapagliflozin? And on the other spectrum, you have a newly diagnosed, poorly controlled diabetic patient, HbA1c for 12 and 13. You have an urge to use insulin to bring this sugar down. Is there any role of SGLT2 inhibitor in the other extreme? Yes, there is a rule. Guidelines state clearly, regardless of your baseline HbA1c, regardless of the target HbA1c, SGLT2 inhibitors should be started, actually should be replacing the standard of medical treatment. You should adjust. Maybe you can discuss this later. How can we do that safely? In a patient who is already achieving HbA1c target and you want to add some more benefit, cardiovascular, renal benefit, how to introduce an SGLT2 inhibitor to these patients, because I notice we have problems in introducing, being too enthusiastic, stopping the insulin suddenly or reducing this. You have to do this in a wise way because patients are different and need to be addressed individually. So the answer is yes. Any patient achieving with HbA1c target, at target, not on SGLT2 inhibitor, or any patient with extreme HbA1c target, they will benefit. And actually, with all of the evidence that we mentioned, they should be on SGLT2 inhibitor as a primary prevention and as a secondary prevention for the complication. Again, this, I mentioned this before. This patient, most of our diabetic patients, you do your effort to address all the risk factors. And you have the landmark studies, the UKPDS, you have the advanced studies, Accord. We address, they thought, we will aggressively, intensively control our diabetic patient achieving HbA1c less than 6.5%. They address all the risk factors, aggressively control the blood pressure, aggressively control the lipids, introduction of ACE and ARBs, antiplatelet activity. Despite all of this, yes, there is benefit. You can see there is clear separation. In the conventional and the intensive group compared to the conventional, you have a clear separation and clear evidence that you help your patient. But as you can see, you are not eliminating the risk. Still, there is significant residual risk. And all what you are doing, you are giving much more time for this patient. Anything, the evidence that we have now that adding an SGLT2 inhibitor to intensive glycemic control and addressing other risk factors will help to address this residual risk patient. So you can do much more on standard care management of this patient, adding an SGLT2 inhibitor. And I think adding this SGLT2 inhibitor as early as possible, you will achieve more benefit than leaving this to the late once you develop the complication, because the evidence here, and even the guideline, GLP-1, they say you use it whenever you have an established cardiovascular disease, once you already have complication. SGLT2 inhibitors, they have evidence that you can use it even before you have established complications. So using them as early as possible will address this small unmet residual, which cannot be met even if you aggressively control your diabetes, HbA1c, aggressively control your blood pressure and lipid. There was something else, and now we know what is something else. It is the SGLT2 inhibitor that addresses the hidden part that was not there. So yes, can we do anything better with aggressive control of the sugar? Yes, you can add an SGLT2 inhibitor, and with evidence you can improve this residual risk and mortality for these patients. I think, sorry. لحظة.